Welcome to Rounds, everyone. I hope everything is set up correctly here. I'm Gillian Shaw, and we'll go ahead and get started. Maybe if I can get the thing to advance. There we go. Okay, first case is a 13-year-old neutered male cat that came with the history of an abnormally small globe since adoption, which was 4 years ago, but prior history was unknown. Exam revealed thesis bulbi with diffuse corneal fibrosis and largely collapsed anterior chamber. January exam, which would have been, oh gosh, let's see here, 2 months prior to enucleation, had dense axial corneal neovascularization with more recent March exam, which was more recent, sooner to the enucleation, showed an axial corneal perforation. Intraocular structures difficult to visualize, and the cat also has chronic kidney disease. So here is the globe. The cornea is always at the top up here. So one thing you can notice is that the cornea is not really translucent or even clear. It's like very white. So this is a diffusely opaque cornea. There's also this little blob of stuff stuck to the corneal surface. Here is the iris. And it sort of blends into this very large off-white mass with areas of hemorrhage in it. And then the anterior chamber is right here, and it has some translucent sort of cloudy gel in it. The rest of the globe has a lot of hemorrhage in it. You can see here. One thing we don't see is the lens. So it was not noted grossly or histologically, actually. The posterior sclera is wrinkled, which is consistent with thesis bulbi. So that's when you get shrinkage of the globe. And down here is the optic nerve. So let's go to our slide now. So here is our subgross view. Let's get ourselves oriented a bit. So here is the cornea. Here's that big mass that was kind of off-white and had a lot of hemorrhage in it that's sort of not sampled well here in the center. Oops. And then here's the area where all that hemorrhage is. And then here is uvea. So this is iris here. One thing you can appreciate that even in the more recognizable uvea, there are these multifocal areas of purpleness or basophilia, and those are areas of cellular infiltrate. The mass itself is quite purple, but it also has these sort of coalescing areas of pink, and those coalescing areas of pink are necrosis of the neoplastic cells. So I'm just going to tell you right now, this is a neoplasm. And then much like the gross photo, we can also appreciate that scleral wrinkling, which once again is consistent with thesis bulbi. So we'll start up here at the cornea. So that little blob of tissue that was stuck to the surface of the cornea is this right here. So the cornea is actually fairly recognizable right here. Here's epithelium, stroma, and then here's Descemet's membrane. And then we lose Descemet's membrane, so it's discontinuous. And what we have is uveal tissue that kind of blends with this deep corneal stroma, which is abnormal. So you can see a tinctural difference between this corneal stroma and this right here. So this is all fibrosis right here. And then you can actually appreciate the deeper stroma is a little bit more normal. So here's Descemet's again, it's a little bit wrinkled. And here's the mass. As I said, it's got areas of necrosis throughout it. We'll get there in a moment. Here is the iris, and you can see those areas of basophilia. So that's some sort of cellular infiltrate. The anterior chamber is here. It has a proteinaceous exudate, which is what gave it that translucent gel appearance in the gross photo. And here are more of what are probably neoplastic cells. We see no evidence of the lens or the lens capsule. So presumably it was extruded through, I didn't actually say this, but this is an area of corneal perforation or rupture. The retina and optic nerve are not well, the retina is not really identifiable. The optic nerve was not sampled in this section. It was probably difficult to identify in the while being sectioned. Okay, so let's jump in here.
What's the gross image this histosection?
What's that?
Was the gross image this histosection?
Yes, it was.
It was not.
The optic nerve is on the bottom of the picture.
Yeah, but it wasn't in the plane of the section.
I know, but they usually section it until they sample it. Okay. Okay. Okay, good. We're in agreement then. Okay. Anyway, so here is that little blob of tissue that is sticking above the corneal surface, which is kind of interesting. It's corneal epithelium with this sort of cavitated space that has some hemorrhage in it. So I think this is just an area where there was a full thickness corneal defect somewhere. And for some reason, the corneal epithelium grew over probably like a fibrin plug or something. And this is what it ended up looking like. Anyway, so as I said, Decimase is discontinuous. So here is Decimase membrane. It's all convoluted and it stops somewhere in here. And then what we have is this uveal stroma, which is blending with the deep corneal stroma. So this is at least an area of anterior synechia. In the iris stroma itself, we actually have the fairly typical population of lymphocytes and probably some plasma cells. Here's a plasma cell right here. So this is part of a very common lesion that we see in a lot of cat globes that we receive, which is lymphoplasmacytic uveitis, which is idiopathic. We rarely know what causes it. And there are various theories about what are the causes of it. But anyway, so let's move over into this mass. So on this side of the globe, the iris just is effaced by this neoplastic mass. And when we start to go higher mag, we can tell that it is sheets of neoplastic cells. They don't really form structures. Some of them have distinct cell borders, some don't. And when we go highest, almost highest mag, they are round-shaped-ish, polygonal to round. They have large nuclei with not very much cytoplasm. The cytoplasm that they do have is a little bit vacuolated. And then they have really prominent single nucleoli. So you can see this guy right here. Off in this corner, you can see a cell that is multinucleated. So there is quite a bit of pleomorphism here with at least moderate anisocytosis and anisokaryosis differences in cell and nuclear size. In this field alone, we have 1, 2 mitotic figures, maybe 3. So it's a fairly mitotically, and this might be a really bizarre mitotic figure. So we have a very kind of pleomorphic-ish, ugly, kind of malignant-looking population of round cells. When we look, and the areas of necrosis, as I said, are all pink. And so in here, we might start to see a little bit of pycnotic nuclear debris and some ghosty outlines, eosinophilic outlines of necrotic neoplastic cells. So this is consistent with a round cell tumor. And in cats, I feel like rule outs number 1, 2, and 3 is always lymphoma. So that is our top rule out for this. I did offer IHC, but they did not take us up on the offer. I did propose that this might actually be, what we used to call the post-traumatic lymphoma. And we're trying to transition the name into chronic uveitis associated lymphoma, or CUAL. And so this type of, the reason why it used to be called post-traumatic is that often it's associated with lens capsule rupture and or other evidence of trauma to the globe. However, a significant proportion of these don't have either of those lesions, and therefore, but they all have evidence of that chronic lymphoplasmacytic uveitis. So that's why we're trying to transition the name to chronic uveitis associated lymphoma. Manuscript in progress. Most of these are large B-cell lymphomas. However, there are a number of them, these post-traumatic ones, chronic uveitis associated ones that can be other versions as well, like T-cell and probably null cell. From what we know, the T versus B cell does not affect the prognosis. So it's pretty much the same prognosis. And that is typically if you have removed the globe with clean margins and it's not invading the optic nerve, it's a better prognosis. But probably these can metastasize away from the eye. Kind of hard to pin down with cats. As I mentioned, there was no evidence of lens capsule anywhere in this globe, so presumably this cornea ruptured and the lens was extruded. And so now it is an aphakic globe. Let's see here. So there is quite a bit of hemorrhage, which is probably originating from the neoplasm itself or something else. This band of purple around the back, this is the choroid that is infiltrated by, once again, those lymphocytes and plasma cells that it's part of that lymphoplasmacytic panuveitis. The retina probably was detached, and I'm not sure where it is now. It could have been completely and diffusely atrophied. It could have also undergone necrosis, depending on ischemic events and such like that. So that is this case. I'm trying to think. I've probably forgotten half the things I usually are trying to say about chronic uveitis associated lymphoma. So here are my diagnoses, most of them at least. So one of the more common historical facts that we usually get with these cases is that this is an eye that's been chronically abnormal. So it was, abnormal since a young cat or since trauma happened or something like that. Often it's a couple of years between when the abnormality is first noticed and when the eye is enucleated and we make this diagnosis. So let's see here. Anything else that I missed here that was all that important? No, I think I pretty much got it. So any other questions about that?
One nomenclature point of view.
Yes.
If we already also have the entity of post-traumatic sarcoma or whatever that'll get renamed to, are you going to call this lymphosarcoma?
Yeah.
I'm asking for real.
Problem
Because the oncology
lymphoma will probably stay the same. Part of
Yeah.
the reason why we're trying to change the name from post-traumatic lymphoma to chronic uveitis associated lymphoma because that it produces a lot of confusion. Post-traumatic sarcoma, like spindle cell variant, is presumably less of a physical origin. It has like a kind of specific pathogenesis maybe that thought that happened. So I think that would probably stay the same thing. But I kind of hope we don't use.
So the question was, are we going to change the name? Are we going to use the word lymphosarcoma?
Yeah.
That's true.
And I just to inform people that it's malignant. Okay.
Well, because there is a trend now in more recent literature to go towards lymphosarcoma
Okay.
to confirm that you're looking at a malignant process.
Okay.
So just
We haven't discussed that, but we could discuss it for our manuscript in progress.
Trends come and go. I remember a time when you say lymphosarcoma, people will look at you and think you were born in the 1800s.
that's how it was trained.
Yeah. Okay. All right. Let's move on to my next case. This is a pretty cool one. Where did my? It's behind the. Sorry. All right. So this is a dog eye. This one is hot off the press. This is an 8-year-old dachshund, intact female. The history we got. History of waxing and waning uveitis that eventually led to severe panuveitis, vision loss, and globe enlargement. Duration of problem was 9 to 12 months, but rapidly worsened in the last few weeks. And the most juiciest part of the history I will withhold. I will tell you that the dog has high total protein and proteinuria. So here's our globe. Cornea is at the top. It's also opaque in this one, so got some corneal opacity going on there. What we can really appreciate is that the ocular chambers, here's the anterior chamber, the posterior chamber is kind of smushed here. We have the vitreal space, and then what is the subretinal space, because this is our detached retina. These are some vitreal strands of stuff. Has this sort of milky white, opaque gel in it. Whenever you see gel in a formalin fixed eye, it means that there's a lot of protein there, which is something that I didn't dwell on in the last case. But so the more opaque it gets, the higher the protein, basically. And so I'm not sure, that's like presumably it's liquid when it's in the dog's head, and then when it's been fixed or cooled away from body temperature or something, it becomes solid. It could be a combination of all the things.
Yeah.
What's that?
Kind of like an egg.
kind of like an egg, but even an egg at room temperature
Oh, I guess.
has, you know, anyway, so I'm not entirely sure if it's the fixation that causes this, because I don't think it's solid like this in the dog's head, but I don't know about that. Anyway, so other things we can see is that the uveal tract itself is a little bit thickened, and that might be hard to appreciate if you don't stare at a lot of gross hemisected eyes, but the iris is thick, the ciliary body is kind of thick here. The lens is a little bit cloudy, so there might be some cataractous degeneration there. And as I said, the retina is detached, it's right down here. So those are the main features, so keep that in mind.
Sure. Brakel here said thinks it's cross-linking the proteins and after fixation, and that makes sense because that's what formalin does.
Yeah, cool, thank you.
Well,
All right, here we go. Oh, wow, that's really pink. Probably fix that somehow. All right. So, oh, cut the slide away. Great, so now it's not pink, it's not white anymore. Hold on. Now it's yellow. Okay, that's slightly better. Okay, so this globe is bigger than the last one because it's not vesicle, it's kind of the opposite. Okay, so cornea is to the left. It's a little bit thickened and it's actually a little bit wrinkled, so maybe this globe is now undergoing thesis as well. But what we can really appreciate is that there's a lot of basophilia, that purpleness in, we have it in the peripheral cornea, the limbal sclera, the iris here, and it trails back into the choroid a little bit. Here's our lens. We can appreciate it at this magnification that there is some fracturing of the lens nucleus. So this is liquefied lens protein here. This is still solid lens protein. So this is evidence of cataractous degeneration. And then, as I mentioned in the gross photo, all of that milky white substance corresponds to this brightly eosinophilic exudate or material that's in all of the ocular chambers and the subretinal space. And then here's our detached retina. Our optic nerve was nicely sampled in this one. So there it is, looking relatively normal, actually, compared to everything else that's going on. The corneal epithelium is present, but it's a little bit, it's quite attenuated, actually, so it's just kind of stretched thin, I think. This is artifact, something to do with cover slipping. And then the corneal stroma is a little bit hypercellular, so we've got a little bit of inflammation and some vascularization. Here's a blood vessel. So as we move back into the eye, here's that high proteinaceous exudate. And when we look higher mag at it, it's just sort of homogeneous to slightly vacuolated. And then the cell population that is floating around here is macrophages. This guy's a macrophage. We've got some red blood cells, and we've got some mononuclear cells. This might be a neutrophil. So we've got sort of a mixed bag of inflammatory cells floating around in the ocular chambers. When we look here, obviously the iris is very heavily infiltrated and its architecture is pretty much effaced by this inflammatory infiltrate. We do see that there are intact melanocytes around, so this does not appear to really be a melanocyte-centric kind of process, as opposed to something like VKH, where pretty much in the most severe cases, you don't see intact melanocytes anymore, you only see melanin-laden macrophages. Now, there are plenty of melanin-laden macrophages around. So this is one, all of these lighter pigmented guys are the melanin-laden macrophages, because no doubt there has been some destruction of melanocytes. What we do have is a mixed population of histiocytes. So all of these guys with the bigger more open nuclei are histiocytes. We have a lot of plasma cells. Here, this guy's got a perinuclear clear zone, maybe almost a clock face nucleus you can appreciate. And then there are some lymphocytes around as well. Most of them seem to be plasma cells here. So we have a plasma cell rich, lymphoplasmacytic, and histiocytic uveitis. This does extend back into the peripheral choroid, but the posterior choroid or central choroid is not really as affected. Look at the lens. So here we've got some degenerate lens fibers. So all of these round blobs are Morgagni globules. So that's one of the hallmark features of cataractous degeneration in the lens. We have a cataract of some sort or another. And then as we move back, here's our retina. So the retina is detached. It's probably been detached for a while because we have shortening of all of those photoreceptor inner and outer segments. And we have a little bit of at least perivascular lymphoplasmacytic, and it looks kind of plasma cell rich once again, retinitis. So those are the main features of this eye. So whenever you have a granulomatous or histiocytic uveal infiltrate, you should be thinking, in a dog in particular, you should be thinking about VKH or canine uveitis syndrome. Typically the uvea in the affected globes with that are diffusely affected, and as I pointed out, the choroid here is not affected. So this doesn't quite fit with VKH. In addition to that, the high protein intraocular exudate is also not consistent with VKH. Same with the retinitis. So the juiciest bit of history that I withheld from you is that this dog actually has leishmania, and it's been under treatment with allopurinol for who knows? I'm not sure. I mean, they've known about the eye disease for 9 to 12 months, so possibly it's been treated for that long. I stared at this inflammatory infiltrate a whole lot, and I also did special stains. I did a Giemsa, and just to rule out a fungal disease, I did a PAS. I did not see organisms anywhere. So I think, considering that this dog is under treatment, maybe it's not surprising that I'm not seeing organisms. I honestly bet they're here, particularly just given the severity of the inflammation and the fact that it's actually gotten worse. I would assume that the treatment is no longer working either for the whole patient or for this eye. So, well, the patient is actually from New York. However, I'm just going to point out the owner's name definitely sounds like it could be from a foreign country.
Okay.
Somewhere in Europe, perhaps. So anyway, these are the main diagnoses here. So leishmania under treatment with allopurinol and that high total protein. So leishmania is known to cause a hyperproteinemia or hyperglobulinemia. They didn't actually tell us what proteins are elevated here. And presumably that is what is leading to some of that high protein intraocular exudate as well. So severe granulomatous to pyogranulomatous and lymphoplasmacytic panuveitis with mild pyogranulomatous endophthalmitis, high protein intraocular exudate, yada, yada, yada. Oh yeah, and also the serum in all of the blood vessels was a similar hue of pink. So that is a very crude way of assessing the protein levels in the serum on histopath. So though I couldn't see any organisms, I assume that this is related to leishmania. So this is a disease that we don't see here in the United States very often. We are more apt to see something like trypanosoma, which from my knowledge has never caused an intraocular infection. We see it in the cornea occasionally, eyelid, etc. But so I assume this dog came from another country with this disease. Also, it's an unspayed female, which is a little bit unusual in the United States. It's obviously not impossible, but an 8-year-old unspayed female dog is a little bit unusual for us here. Anyway, that's it.
Yeah, the what?
What's up?
Yeah, I don't remember. Well, back when I was in Brazil, that we saw a lot of leishmania cases. We couldn't treat pets by law just because they don't want to cause any degree of drug resistance, because I think there was only one type of treatment for humans, and I don't remember what it was that they used to treating.
I know allopurinol, we don't use it for anything like that.
Yeah,
It's weird.
I don't know. Dr. D asked a question I was going to ask you. I think I know your answer, but that'd be a good point to see that. So he asked if you use the word hyperviscosity or not in this case.
I did not actually, and in retrospect, I think I should have, except that the only thing that we have so hyperviscosity syndrome is when you have something causing increased viscosity of the blood in the eye. So it can be caused by leukemia and that can be white blood cells or red blood cells. It can also be caused by serum protein that's associated with, for example, multiple myeloma, and we get hyperglobulinemia. And I can't remember what else.
Chronic inflammation from
Right.
Ehrlichia is a good example,
Okay.
but leishmania wouldn't surprise me.
Yeah, so leishmania is actually on the list of things that can cause hyperviscosity syndrome. I didn't use that, I think in part because this one didn't have all that much hemorrhage, and I didn't see the degree of
Necrosis,
uveal and retinal necrosis that I would have wanted to see to call it hyperviscosity.
Yeah, when I said I think I know why it didn't, that's exactly why. I agree.
Yeah.
Hemorrhage and necrosis.
Yeah, but certainly the high protein intraocular exudate is strongly suggestive of it. And
Saying
yes,
that,
I probably should have used that somewhere in the diagnosis so we could find it again.
see where
Yeah.
brain fusion is happening already. As I say, I was just gonna say, if you put that hyperviscosity there, I wouldn't mind at all either. So,
Yeah. Okay.
cool.
All
We
right.
had one case of leishmania in Wisconsin, like in-house, like a while ago. It was, I think, Clint Path made the diagnosis on a joint fluid. Everybody panicked, and I did the same thing. I read the name in the submission of the owner, and I was like, this person is Brazilian. My Brazilian radar was 100% on, and I contacted the person. It's like, yeah. And they were from the exact location in Brazil where our vet school is, where there's leishmania everywhere. And they had just brought the dog with them like a couple months prior. So everybody was relieved in a way. They didn't have autologous like case of leishmania in Madison, Wisconsin. But
Oh, I should also point out that to actually confirm it, here is difficult. I'm sure some human labs have various tests that they can do. And I think there's serology that can be done here in the United States, but actually IHC, I don't know where it can be done. And we tried like 8 years ago to send stuff to Spain to get some stuff done, and customs just like ate it alive. I don't think it ever even arrived at the lab. So we probably did something wrong in shipping it. But yeah, so actually confirming it is actually a little bit hard on this tissue, but I don't think we need it.
Maria Shank also mentioned that there's a pool of leishmania in Kentucky of all places,
Oh,
mostly in foxhounds from a certain area.
Yeah.
Just FYI.
That's a different disease. That's a
Yeah.
different disease.
A different disease. Okay. Cool.
All right.
Cool case.
All right. Good morning. I'm Jamie Miller. Notice Staff Pathology here at Coplow. I'm going to keep us going with 2 more cases here. So this is the left eye from a 13-year-old female spayed Chihuahua with the history of glaucoma, blind. Please rule out intraocular tumor versus other, and perforation. And yes to glaucoma, and that is what we got. So, heavy section of the globe, cornea again is at the top, and we can see that we can indeed confirm intraocular mass here. It is kind of expanding and facing the ciliary body and the iris, kind of filling the globe a little bit. The retina is also diffusely detached. It's a little bit thickened. There's maybe a little bit more whiteness, mass-like lesion there. And then we can also confirm the perforation here, where the limbus here gets a little hard to make out, and you can see the tumor extending out through there. Let's take a look. Okay, so kind of our same view. Our cornea is a little bit tangentially over here. Here is our lens, and then here again is our mass, kind of expanding and facing the uvea here. There's also more similar tissue here, kind of carpeting the retina. And then again, here it is extending through. We can see our loss of our sclera here and the mass extending out. And here's our optic nerve, which actually looks relatively okay. So, cornea is here on the left, and as said, from low power, here's our neoplastic tissue that is expanding and effacing our iris and ciliary body. We're just going to jump right in here, and we can see what we have are these sheets of cells that are kind of round and polygonal. Got very distinct cell borders, usually pretty distinct. You can kind of pick them up with some imaginary tweezers, if you will. They have moderate amounts of eosinophilic cytoplasm, the nuclei are round oval, with kind of a finely dispersed chromatin, prominent nucleolus. There are areas where we get some large multinucleated cells. So we got some pleomorphism here, mitotic figures as well. So it was a mitotically active tumor. I think I got 22 in 10 high power field. But they're generally forming sheets. In some areas, there might be, they are forming maybe some vague nests as well. And this neoplastic population extends all the way back here. We can see it again, similar cells are lining this retina that is detached, it's kind of underneath here in the subretinal space, but it's still within the globe, so they did remove it all. With sort of this degree of pleomorphism, we start thinking about things like histiocytic sarcoma, its location in the uveal tract. We also have to keep malignant melanoma on our list as well, because it can kind of do it at once as far as its morphology. So those were the two top differentials for this mass. Again, as we head over here, here's our cornea. The epithelium is pretty hyperplastic, got some keratinization, lots of inflammation, because again, we lose our collagen here at the limbus, and we can see the neoplastic masses leaving the globe here, and maybe a little bit of the uveal tract as well. Additionally, the lens capsule is also ruptured. And we can see inflammatory cells, to get in focus, coming in and starting to nibble at these exposed lens fibers here that are also kind of degenerate and cataractous as well. So we've got a uveitis and lens capsule rupture with this mass. Here in the globe, retina is detached, as I said, but again, optic nerve looks pretty clean, so that's good. So we did offer CD204 for histiocytes and melanoma for melanoma to help narrow down what type of tumor this was, because they kind of have different prognoses for the patient. Histiocytic sarcoma, usually when we get it, it's a very poor prognosis for the patient, usually about a 3-month survival time, whereas a malignant melanoma, not as bad for the prognosis for the docs. So this is a CD204. So this is marking our macrophages. So we can see these lot of like spindle shaped shells. Oh my goodness, cells that are staining positive for CD204. And they are kind of squeezing in between all of their neoplastic cells. So this is actually most likely dendritic macrophages being called in by the tumor. And so our neoplastic population is negative for CD204.
Positive for M2 alternate polarization of the macrophages.
And then, so our melanoma is very positive. I think it wasn't maybe a diffuse positivity, but the majority of the neoplastic cells here have a nice, strong, positive cytoplasmic staining. So this is consistent with a malignant melanoma. Oh my goodness. Keeps jumping back and forth. Okay. Did mention that that kind of posterior carpeting over the retina is a little bit odd for melanoma. Usually they're primary to the eye, but they can have metastatic disease or be metastatic to the eye. So we did caution to probably stage the patient just to make sure that it hasn't come from or gone elsewhere as well. All right. Moving on. Next up, this is the left eye from a 10-year-old male neutered mixed breed dog. They said clinically that the left eye was ophthalmic, had negative menace and dazzle response. They noticed some amorphous clear to white blobs of material in the anterior chamber, and that there was some posterior synechia. Let's see. They didn't note any abnormalities in the lens, but noticed that they couldn't see it very well as well, and that the fundus was not well visualized either. They said yes to glaucoma, been going on about 2 months. Otherwise, the other eye has a little bit of nuclear sclerosis and some incipient smudgy cortical cataract. So we got the left globe. It was ophthalmic. Here's the cornea at the top. We can see a little bit of kind of opaqueness to the anterior chamber here. Here's some of that kind of white material, which is probably what they were seeing clinically, that amorphous clear to white stuff. Our uvea, our iris here, has this little tan carpet on the front, and also carpeting the back of the iris and the ciliary body here as well. Our lens is a little bit cloudy. We can see more wispy material here, and the retina detached. So, rest up gross view, cornea at the top. We can see a lot of eosinophilic material in the anterior chamber. This kind of bright linear pink stuff is wrinkling artifact within the tissue. So we have a little bit of an exudate in here. We can see our iris, and we can see that there's that purple lining, that carpet on the front of the iris that we're seeing in the gross picture. Here is our lens. You can start to see a little bit of cataractous degeneration here as the lens fibers start to get a little bit liquefied. And here's our retina that is detached and maybe slightly thickened. We'll take a look at that as well. So starting with the cornea, there's a little bit of peripheral keratitis and vascularization, possibly secondary to the ophthalmia. But our main event going on here is in the uveal tract. So we have the iris, it's very thickened, it's very purple, and we can see sort of this carpet on front here. It does cross the iridocorneal angle, causing some peripheral anterior synechia as well. And it carpets the pretty much the entire uveal tract. We take a closer look. What we have mainly within the uveal stroma are these lymphocytes and plasma cells. And on the surface, we have this carpet of epithelioid macrophages, which also seem to be phagocytosis, some eosinophilic material. Could be some of the material that's in the anterior chamber, could be some red blood cells, but it also could potentially be some lens material. So we can see this epithelioid carpet again carpets the rest of the uveal tract. We can see that inflammation, lymphoplasmacytic also continues as well in the choroid. And if we head back towards the retina, much a little thick and raggy because it has also got a epithelioid macrophage carpet to it as well. Looking at our lens. You can see some of our nice intact lens fibers, and then we lose that nice discreteness to them, and they become liquefied. We start to see some rounding up, so some more ganglion globules. Again, features of cataract degeneration. And then outside of the lens capsule here, that was mainly intact, we have these eosinophilic globules of lens protein. And so again, that could be what part of what the macrophages were gobbling up in that carpet. And we are also seeing that stuff, that lens material up here in the anterior chamber as well. So again, this also might have been contributing to what they were seeing clinically with the amorphous white blobs in the anterior chamber, kind of coupled with this proteinaceous material here. So this inflammation in the uveal tract, this lymphoplasmacytic inflammation, coupled with the carpeting of the epithelioid macrophages, and with this cataract formation and this leakage of the lens protein here, is consistent with what we call asynchronous uveitis. We're trying to get it's also asymmetric uveitis might be what people are familiar with at the moment, but we're trying to get it changed to asynchronous uveitis to kind of these dogs usually present with one eye is affected first. And because we think that this entity is a hypersensitivity to the lens protein that gets leaked out of a cataractus lens. And so the lens protein gets leaked, you get an immune response, you get this type of inflammation, and it sort of sensitizes the body to the lens fibers. This kind of indicates that the other eye is also at risk for developing this sort of intense inflammation. If there's, cataractus change or any sort of reason why there would be other lens leakage protein in the other eye as well. So it's a little bit different presentation than say like bilateral symmetric uveitis, like with VPH or uveodermatological syndrome. So the asynchronous nature is more the kind of clinical importance for this entity, which is why trying to get the name sort of switched over to that. I think manuscript is in process for that as well. I think that was all I have. I left you a little bit of time there, Megan.
You have a proposed hypersensitivity mechanism for that?
We would love to know.
Let's
Maybe we can work together on that.
figure it out.
Yeah, we don't.
It doesn't seem like it would be a type 2.
Mhm.
They're type 4.
Yeah,
Type 3 also. That's what you're leaning toward.
probably.
Okay.
My name is Megan. I'm one of the staff pathologists at Coplow. So this is a 14-year-old spayed female domestic short-haired cat. Presented for glaucoma of the left eye. The owner first reported anisocoria approximately 2 years ago, according to the primary vet. That's pretty much it. Also some diabetes, pancreatitis, feline asthma, probably not related to the ocular. So this is a representative photo. We didn't get a gross photo of the actual case I'm going to show you the slide from. So this case probably didn't quite look like this.
What I'm mostly trying to show off is this part in this cat's eye, which is a very thin area of sclera, roughly equatorial and dorsal, which is outcouching slightly. So this grossly is consistent with a staphyloma, and we would investigate that closer. This case probably has a little bit of angle recession, but otherwise, the other thing I'm trying to point out is that the gross appearance of this globe was probably otherwise quite normal, or unremarkable. So ignoring some of the other things that this specific representative cat maybe had. That is correct. Let me show you a slide, but it doesn't necessarily work. All right. We've got cornea on our right. You can see that it's pretty normal. And we did have glaucoma in this case, and you can see from this low magnification that the ciliary cleft and iridocorneal angle are nice and open. You can see these nice, delicate, distinct, and individualized pectinate ligaments. And you can see, we'll drop in on it closer in a bit, but this nice rarefied looking site here, which is trabecular meshwork, also kind of open and looking nice and normal. This is the dorsal side. If we walk back towards the equatorial globe, you can see that both of the sclera and the uvea get quite thin here. So this is our site of staphyloma, and this is basically what a staphyloma will look like histologically. We walk around to the back of the globe, you can see that the optic nerve is absolutely cupped and atrophied, like whoa. So glaucoma check. You can see from low magnification that the retina does have its layers still, but we'll look closer because the ganglion cells are definitely lost. And this is showing off how cats tend to maintain the basic architecture of their retina, even in chronic glaucoma. But the retinal ganglion cells are usually totally lost. That one is just sort of artifactually a little bit narrow, I swear. We'll look at that closer, but also showing off on this side that, again, the angle looks pretty open and well-formed. So what's causing our glaucoma is the question. And if we walk this a little ways over into the sclera, let's take a closer look at these vessels of the scleral venous plexus. And you can see that around each of these vessels, or at least many of these vessels, there's this sort of halo of poorly staining matrix, sort of mixoid-like matrix is what we tend to refer to it as. And this is a fairly repeatable finding around the quadrants of the globe. So basically, we don't have a clear structural histologic cause of glaucoma. The angles look open and well-formed, but we do have this weird matrix deposited around the vessels in scleral venous plexus. And what this presentation is most consistent with is feline primary open-angle glaucoma. This is presumably a primary glaucoma, which is associated with a probable post-trabecular obstruction, but the exact mechanism of action is kind of unknown still. It tends to have an onset in adult cats. It can be either bilateral or unilateral. Let's see, the figure is that approximately 60% of the patients in the Coplow collection had bilateral disease. And then if there is bilateral disease, the approximate time to onset in the remaining eye is about 399 days with a range of 0 to 1,795 days. So some details there. And this is just an interesting case to show. Basically, if you have a cat that has a clear glaucoma and a really open and well-formed iridocorneal angle, ciliary cleft, pectinate ligaments, trabecular meshwork, basically there's no structural cause of the glaucoma, I would recommend looking for either this feline primary open-angle glaucoma or aqueous misdirect syndrome. Those are kind of the two big cat ones that don't cause obvious structural malformations of the angle. We can run back really quick to show off the retina that I promised you that does still have its layers, except for there's no ganglion cells. We walk along this. So definitely a nice chronic glaucoma in this case. So that's it. Relatively quick and straightforward case.
I'm gonna get on my soapbox for a moment.
Please do.
I really don't like this is called primary glaucoma.
Interesting.
Primary glaucoma, in my opinion, should be reserved for when there's an actual malformation of the iridocorneal angle leading to decreased aqueous humor outflow and high IOP and glaucoma. There's nothing wrong with the iridocorneal angle in these globes. So it really irritates me that it's called primary open angle glaucoma. Open angle is fine because it's an open angle, but I really don't like that it's called primary. I think honestly the problem is outside of the eye.
Yeah, post-trabecular.
We just don't know what it is.
Yeah.
I would say well, the idea, I really enjoy, I really like this lesion and this disease. And it's such a bummer to be a little bit obsessed with something like this because it's rare and it's really hard to study because it is something very physiologic, right? I'm trying to put together documentation for a larger paper. I think we're almost there. And the idea will be to call this post-trabecular. Primary, it's such a confusing term to begin with. Some people would say that historically they decided to call primary open angle glaucoma in a sense of there's nothing secondary or there's nothing that can be morphologically identified to explain the glaucoma. And that's why they call it primary. It wasn't me, don't get mad at me. But I think it was more on that sense. But I 100% agree with Gideon.
Yeah.
Primary just makes things more confusing.
I guess in human medicine, they call it
Yeah.
primary open angle glaucoma, and it might be a similar thing where it's actually nothing wrong in the eye, but from a canine perspective of glaucoma,
Feline
we call
disease.
primary
Yeah.
glaucoma in dogs because associated with goniodysogenesis.
Mhm.
So, yeah,
Anyway,
anyway,
that's just kind of muddy
So-
waters, so I
Yeah.
agree.
My question to you then is, are you calling primary something that is congenital, a congenital anomaly versus an acquired anomaly?
That's good.
So is it primary because it's not acquired? And then in that case, I think primary is appropriate. Or if you're just distinguishing between
well.
Right,
except
primary
it might be-
versus acquired.
Except that it's not all the
But it
time.
sounds like it's a combination of both.
Yeah.
Yeah, which is kind of
Yeah.
what gonio is too. It's kind of a
Exactly.
combination of both as well. So yeah, it's weird.
Yeah, and that's the main problem. The nomenclature is not clear and it can be confusing because of that. There are many arguments that can be done in both ways.
You know,
And it's not such a important or a specific enough descriptor word that one can make an argument, oh, we should leave it there because it helps explain the pathophysiology, which sometimes is useful. That's not the case. So I'm not married to it. And, yeah,
Cool.
maybe we'll try to change that soon.
Publication pick. I'm seeing.
Yeah.
The theme of this
Yeah.
Can add that to every single case,
Yeah.
publication pending.
Yeah. Right. Okay.
Sorry, Meg.
Yeah. No worries. I'll see if I can get through this horse in like 8 minutes, but we'll see. I thought it was so clever in how I planned things, but we'll see. All right. So this is an 18-year-old Andalusian stallion. This horse has a long, detailed clinical description, which I'll try to summarize. The current owner bought this horse about 6 weeks prior to presentation for eye disease, and does not know previous medical history. That's interesting. In this eye, the right eye, they said there was Hobbs-stria, there was keratotic precipitates, there was sort of partially formed anterior chamber, partially collapsed, an eccentric and discoid pupil, a pupillary membrane, sort of fibrinous-looking membrane along the pupil, and then yellow to green discoloration of the lens, and they couldn't see much past that. They did confirm iris Bombay via ultrasound, via microscopy, and there are kind of some similar, like maybe inflammatory looking stuff going on in the other eye as well. So the other eye is also abnormal. On gross evaluation of the right eye, you can see that sort of partial iris Bombay here. So this thin pigmented tissue that's plastered against the cornea is a anteriorly bowed iris leaflet. And then the partial formation of the anterior chamber on this side where the iris is less billowing forward. We do have a lens that is luxated, so it's posteriorly luxated way out of position. And then the retina is detached and sort of wrapped around the lens in a fun sort of a way here. And because the retina isn't really obviously attached somewhere around this area, maybe where oris serrata or oris oris retinae should be, it's most likely torn as well, so probably detached and torn retina. And then, yes, cataract, the lens looks fairly opaque here. All right, histology. There we go. So we can see that the anterior uvea is looking a little bit purple, so there's some cells there. Here's the lens capsule, and the lens capsule is still in place more or less in the posterior chamber. It's fused to the back of the iris, or the iris is fused to it, or both. It's ruptured, so we can see that the posterior lens capsule is kind of curled on itself and discontinuous. If we walk all the way across to this side of the posterior chamber, you can see it's the other end against the ciliary body here. And even though this end of the lens capsule is fairly sharply discontinuous and sort of boxy looking, it is still curled on itself and also embedded in this membrane, which tells us that this is a real lens capsule rupture. In addition, the rest of the lens is back here. So what we saw on gross was basically just the lens fibers that had popped out of the lens capsule or bag and are just sort of back here, luxated posteriorly. And we'll look at that closer right now, because why not? If we go to the edges of these remaining lens fibers that are exposed and looking kind of ruffled looking, look closer. And focus. Here we go. We have all these adorable macrophages lining the exposed ends of the lens fibers and phagocytizing them. In Coplow, we call this phaco spaghetti. That's not a scientific term, as you might have guessed. But it's a fun term. So, yes, manuscript pending. No, not really. The way to describe this is that they're phagocyzing the lens
You're
fibers.
sending over to culinary pathology
Yeah.
journal.
Balls.
Spaghetti meatballs.
But regardless, the presence of those macrophages nibbling on the lens fibers helps to confirm that this was indeed a true in vivo lens capsule rupture with extrusion of these fibers, and the macrophages are responding to them as if we needed additional proof that it's a real rupture, but it is additional proof. If we walk back up here to the lens capsule real quick, we can see that there are lens epithelial cells inside the lens capsule still, and then they migrate outside of the lens capsule and are part of what's forming this membrane along the ciliary body surface. So that's kind of cool. We've got extralenticular migration of the lens epithelium. We'll run back over here really quick and drop in on this purple area just to show off that it is inflammation, just really quick. So yeah, here's an anterior uveitis lymphoplasmacytic. So we've got that. And the last thing that I'll show in this case is the retina, which is detached and pretty severely atrophied, often full thickness. It's a wild ride. All right. And then also multifocally torn. And we can tell that it's a real in vivo retinal tear because we do have this rounded end when the retina tears in the body. It sort of has this rounding up action that it does. Artifactual tears tend to be more boxy and sharply discontinuous at the torn end. We'll switch back over to here. I did it. I have 2 minutes left. Yeah. So anyway, I'm very excited about this. So here we go. These are some of the diagnoses. And the main thing here is that this was most likely an ocular trauma at some point, causing lens capsule rupture, retinal detachment, and tear. Sometime in the indistinct history pre-current owner. And they had a question about ERU, or equine recurrent uveitis in this case, because the other eye has kind of some inflammatory seeming signs. I didn't see an amyloid carpet along the ciliary body surface in this case. There was a lymphoplasmacytic uveitis, so there is a uveitis at least. And basically what I would say is that if you don't see the amyloid carpets, it may just be that like in some other quadrant somewhere, maybe I would find it. So I'm not sure I can necessarily rule out equine recurrent uveitis in this case, but at least the findings weren't, specific for pathognomonic for it. So just some interesting stuff. Mainly the interesting thing about this case is signs consistent with trauma. And that's it. All I can say about this horse.
All right, perfect. Thanks for joining us, everyone out there. And I'll see you guys in a couple of weeks.
Thank you.
What?
Stop recording.
Oh, yeah, of course. I can figure this out. Wait, where's the button for that? Here.
Right there.
Wait.
More.
Is it?
More.
Oh, God.
Okay, here we go.